Hey everybody, welcome to this very special live in-person meetup. We're here in Los Angeles. I'm here, Dr. Green, as you can see, is sitting right next to me. Anna is in Chicago online. She's lending her support since we have some extra circumstances to deal with today. Basically, we're here live at the Godfrey Hotel Hollywood, and we are going to be answering your questions about perimenopause, menopause, and postmenopause, and anything else that might come up. We're here for about an hour, so wherever you are, look at your clock. Know that in about 45 to 50 minutes, we're probably going to end. We will try to get to everybody's questions. We do have some that were submitted earlier. We will try to answer most of those, and to any that are online. Anna, I'm going to ask that you please let me know what the next question is. You can message me via our chat and just give me a heads up as to what the next question is. I'll be also reading off the pre-submitted questions. So we're going to go ahead and get started. I'm going to let Dr. Green introduce himself, even though you may know him. I'm going to let him take it away.
So hi, this is kind of exciting. This is the first time we've tried this, so hopefully it goes well for those of you here and those of you online. My name is Mike Green. I'm the Chief Medical Officer of Winona. I'm also an OBGYN, and for many of you, your personal doctor at Winona. So great to meet you, those online and in person. So first, I've got a huge apology. I know that we build this and advertise really to a big extent that we were going to have Joshua, our big pharmacist here, and we were going to go over the the science of compounding. Unfortunately, he had a family emergency. Actually, he's been gone almost a week, and so he's not able to join us. I really don't want to do it without him, so we're going to do our normal sort of everything goes Q&A. Still, you can ask me about compounding. But we're going to, hopefully next month, we're going to do this and really go in depth about compounding because it's really important. So those of you who have been to the Q&As before know that I usually start off with like a little monologue, mostly to kill time while you guys are putting questions in. So please start putting your questions in. It gets really uncomfortable if there's no questions, and then we start doing song and dance. So please put your questions in. I'm going to do a little short blurb on compounding. It won't be obviously as in-depth as when we do this for real, but I just want to kind of give you an idea. So one of the things we do that's different than a lot of other companies is we do have the ability to provide hormone replacement therapy in compounded creams. And I think this is really good for lots of reasons. Probably the biggest reason is it gives us more tools. So I teach residents, which is a lot of fun. And one of the things I tell residents is try to learn as many different ways of doing the same thing as possible. Because the more tools you have in the toolbox, the better chance you're going to be able to get the right tool for the right patient. And it's really important in medicine because one thing doesn't necessarily work for everybody. And if all you have is a hammer, the whole world starts looking like a nail, and that's not really a good way to do medicine. So compounding gives us another tool, another way to treat you that sometimes may work better than the traditional pills or patches or other things that are out there. So I think it's a real good thing for everybody. Compounding really is a bit of an art, and this is where I really need Joshua, but basically you have these really highly skilled pharmacists. They're really specialized, and they take the base medicines and they compound them into a cream in various strengths. And there's a ton of data for this that it works really well for a lot of people. It also allows us to make really specific types of hormone replacement therapy that may not be available by big pharma in the commercially available pills and patches. So it gives us kind of a lot of leeway to tailor things for you and make things as good as we possibly can. So those are some of the big benefits of compounding. There's some things about compounding. Everyone's laughing. I don't know if you guys hear this online. There's a bunch of bar noises with the shakers and everything going in the back. So I've got my Diet Coke here. I'm going to wait till we're done before we hit the bar. But anyway, those of you can enjoy yourselves. So there's some things about compounding that are a little bit controversial. And the first thing is this idea of whether that is that by definition, a compounded medication is not FDA approved. And that's because there's a question. Okay, sorry, I'll pull this up. Okay. Thank you. I do too, actually. I'm an obstetrician. I've spent 30 years with like really loud ladies that are trying to have a baby. So my hearing has suffered from that, unfortunately. And you know, I don't blame them for it. But okay, so this FDA approved thing is a sticking point for some people. And the problem is, as soon as you take a medication and you alter it in any way, no matter how well that's been studied, it no longer falls under FDA approval. So you can take something that's FDA approved, grind it up, put it in a cream, and it's no longer technically FDA approved. Doesn't mean the medicines don't work, doesn't mean there isn't a ton of data for them, but they aren't, no compounded medicine is FDA approved. And so if that's something that's important to you, then compounded medicines aren't the right thing for you. You should get a pill or a patch, and those are FDA approved, and we have those as well. So, you know, a little bit for everybody. So that's one of the controversial things, but it doesn't mean we're not under like government watch, okay? So our pharmacies they get inspected, we've got to do everything by the book, and we're really, really careful. Number one, because your safety and health is absolutely the most important thing. And number two, from a very practical reason, if we start cutting corners and we get caught, we lose our whole business, and we don't want to do that. So we're super, super careful, particularly with your safety, to do it right. So there's a...
I have a question.
Okay.
Since you were talking about bioidentical hormones, there's some studies that show that there are some differences. I know that some endocrinologists are saying to stay away from it. Like, what are your, I haven't read the studies, so I don't know, but what are your thoughts on that?
Sorry, some endocrinologists are saying, I lost that last.
Saying, like, stay away from the bioidentical hormones, just from
So that's interesting. So all bioidentical means is that the hormones are chemically exactly the same as what your body makes. There are synthetic hormones that are called biosimilar hormones because they're not bioidentical, that are similar to what your body makes, but they're not exactly the same. Many of the pharmaceutical hormones are bioidentical hormones. So the word bioidentical gets thrown around in different things. So really, bioidentical hormones are ubiquitous, and it's pretty much become the standard of care. I think that those are really the best hormones, and most people agree with that. I think, I hate to say what you're thinking, but the controversy is more in the compounded hormones rather than the bioidentical hormones. So you can take an estradiol and sell it as a pill that's from Big Pharma, and I don't think anybody has an issue with that. The question is, if you then grind it up and put it in a cream, that's where people wonder, is it still working?
Or do it in pellets, right?
So pellet's another issue. How many questions are we missing? Okay, well, let's, sorry, no. Here's the thing, I'm a king of rabbit trails, and I could talk all night on rabbit trails. Pellets let's talk about pellets, but let me finish this thought process first, because I could spend the whole night talking about pellets. Let's finish this other thought first. So that's the one thing about the bioidentical. The other one is the progesterone. And progesterone is a bigger molecule than estrogen, so it doesn't absorb as well through the skin. And so some people worry that using progesterone through a cream isn't going to give enough progesterone to protect the lining of the uterus. So the real reason we use progesterone is that estrogen does most of the work. And estrogen can overstimulate the lining of the uterus and cause problems. So you need to add progesterone in women that still have a uterus so that you don't have that problem. And when you add them both, you actually have a lower risk of uterine cancer than if you weren't on anything. But it has to be done right. And the problem with the progesterone creams is they're tricky, and they have to be done well. And so you can buy a progesterone cream on Amazon without a prescription that honestly is sort of progesterone in name only. They put a teeny amount of progesterone in there so they can call it that, but there isn't any real amount of progesterone. And so people have had problems because they're taking estrogen, they're buying a progesterone cream from Amazon or somewhere else, and they think they're being protected, and they're not, and they end up with problems. And so a lot of the big organizations like ACOG and NAMS have come out and said, hey, you got to be really careful about this. And you know what? I agree with them. And if I was a guy writing the statement for ACOG or NAMS, I'd write the same thing. I can tell you that we're really careful about this. So when you use micronized progesterone in your cream and you do it at the correct dose, and that's really the key, then you have enough progesterone to protect the endometrium. And there's lots of data for this that shows that it works. And the other thing, we've been in business now April will be 3 years. It's kind of amazing. And we've seen tens of thousands of patients in that time, and we haven't seen any problems. So just empirically, we know that it's safe. But there's a ton of data, real studies that do show. So those are kind of the two things that people talk about with compounded medications. And those are why we feel at Winona that they're very safe, and it's a really nice tool. And it's not for everybody, but it's nice to have for people where that's going to be the right thing. So those are sort of the introductory remarks. Why don't we hit some questions? We'll come back to the pellets, because I do want to talk about that. But let's hit a question from online.
Okay, great.
Hey guys, Angela and...
Okay, so I know we've been waiting. So there was a question in here. We have a lot of questions that are coming through on compounding, and I know since our main pharmacist isn't here, I might skip some of those just because we're going to probably have Joshua back so that he can speak to some of the compounding questions. So we will answer compounding questions, but I want to also address other things besides that since the expert on the topic isn't in the room. I mean, aside from Dr. Green. Sorry, don't present company excluded. So first thing I wanted to mention is we have a question about how common is it to go through perimenopause in your 40s. Like we hear a lot about women in their 50s or early 50s, but women in their early 40s, maybe even younger, are going through perimenopause. How common is that?
Yeah, that's a great question, and it's one that gets brought up a lot, and honestly, it's one that a lot of doctors botch, in my opinion. So here's the statistics. The average age to complete menopause is in the United States is 51. Completing menopause by definition, and it's kind of an arbitrary definition, but the definition is that you've gone 12 months without a period. So the average age of that is 51. We know that the symptoms can start 7 to 10 years before that. So if you just think about the average woman at 51, so take 10 off of that, at 41, she's starting to have symptoms of perimenopause. So that means that, half the population is getting symptoms in their early 40s. So it's incredibly common. Not only that, about 15%, 1/5 of women complete menopause by 45. So take 10 years off of that. That means that 15% of women are starting to experience symptoms at 35. And I can almost guarantee you that you're 35, 36, 37, and you go to your doctor's office and you complain of these symptoms, they're going to think it's something else, okay? And unfortunately, there's just not a lot of education on this. But it's really true, it's undertreated. And people suffer needlessly, and they get put on antidepressants, and they get, let's do this or do that, or, it's your diet or this and that. And those things may be the case, but a lot of times it's perimenopause symptoms and people are missing it because they think, you're too young for that. And, nobody wants to think, we all want to get old gracefully. Nobody wants to think, I'm of that age, okay? But on the other hand, you want things taken care of so you can live better. And we know that the longer you go without getting treated, the more risks you have medically. And let's face it, you're uncomfortable. You might as well live the best life you can. And if taking some medications helps you feel better and really perform and feel the best that you can, why not? And starting it early does give you health benefits. So it's really, there's this big misconception. I think people are starting to understand this more and more, but really the education for menopause in training is really, really sparse. That's the right word. It's very little, and we just don't get trained. And so there's just a lot of misconceptions. There's a lot of people uncomfortable. I can tell you the Kaiser system, which in California, particularly, probably outside of Medi-Cal, the biggest health system in California, and they take Medi-Cal, so they probably are the biggest health system in California. They pretty much, as a rule, don't do hormone replacement therapy. They'll prescribe some synthetic hormones if the patient really pushes, but they pretty much don't do it. And really, it's too bad. Good for us, because we get a lot of their patients, but really I'd rather that people get treated when they need to get treated. So there is just a lot of misconception out there. So I kind of beat that one to death. Let's go to the next question.
Okay. We have a question. It's an important question. So Jody wanted to know, this is an online question, she's at moderate risk for breast cancer, and she wants to know if HRT is still a viable option for her.
So, great question. So, with all this DNA studies that are out there, you can send your DNA off and all this. People start getting these kind of risk assessments of breast cancer and other things which is good. It's a good tool, but it's something that we didn't really have before. There are certain things that really put you at really significant risk of breast cancer, and the biggest ones are some of these really hard genetic factors like BRCA genes, the Lynch genes, a couple other genetic factors. Even with those genetic factors, some people think that it's safe to use hormone replacement therapy. So actually NAM says that, and ACOG2 says that with correct counseling, that's something that could be done. I can tell you that at Winona, we feel uncomfortable with that, mostly because we do asynchronous telehealth. And as the chief medical officer, I feel like we can't really have the in-depth conversation that needs to happen to do that right. And so for those women, I encourage them to see an inpatient doctor where I just think they can get better care. So one of my things, and one of the things that really the whole company has bought into is that we're very happy to turn business away if it means patient safety. And there's really, we try and do what we do really, really well. And, we don't sort of push the envelope and take risks with patients, to get more business. I just don't think that's the right thing to do. So for those situations, I really think you really need an in-depth conversation, probably a conversation with a genetic counselor, things like that. These sort of moderate risks, it doesn't mean you don't have moderate risk, but I feel very comfortable with most of those providing hormone replacement therapy. We know that even a very close family history of breast cancer, hormone replacement therapy is safe for the woman to take. Not the person that actually has a breast cancer, but let's say that your mother and your sister has a breast cancer and you've all tested negative for the BRCA gene, for instance. That's actually very safe to use hormone replacement therapy. So, and that's another thing that people don't understand. The studies, there's 2 huge studies that looked at this, and they both come up with the same thing, is that, no, actually, it's very safe. Doesn't mean you won't get breast cancer, but if you do, it's not from the hormone replacement therapy. The breast cancer thing is really misunderstood. There's a very slight increased risk of breast cancer with estrogen and progesterone combined hormone replacement therapy. For women without a uterus that get estrogen-only hormone replacement therapy, there's actually no increased risk of breast cancer, which honestly was a surprise for me when I found this out. And full disclosure, 3 years ago, really longer than that, 4 years ago, 4.5 years ago, when we first started talking about this, I started reading everything I could about hormone replacement therapy. I thought I was an expert at it, and I wasn't. And I learned a ton. And that was one of the things I learned that really surprised me, is that the risk of breast cancer is really overstated for hormone replacement therapy. It doesn't mean it's not there, but it really is pretty minor. And when you look at the big picture, and I've always been a big picture guy, if you look at life expectancy for women that start hormone replacement therapy before the age of 60 that are appropriate candidates, they're more likely to live longer and healthier lives than women that have never been on hormone replacement therapy. So even if it slightly increases that risk of breast cancer, it greatly reduces the cardiovascular risk. You have less chance of a heart attack or a stroke. It reduces your risk of colon cancer, uterine cancer, other kinds of cancers. So the net sum, which is really what's important, is that you're going to live longer and healthier on average if you use hormone replacement therapy. And I think that's the way to look at it, because that's the goal, really, right? We want to live as long and healthy as we can. I mean, the one thing that you can say that pretty much everyone in the world will agree with is that everyone has to die at least once, okay? And so, it's going to happen eventually. So hormone replacement therapy is not going to keep you from dying, but it's going to put that off a little bit longer and keep you healthier. So that's kind of the big picture.
All right. I'm going to keep Dr. Green on the under 3-minute answer. Sorry, just in the name of time, because we have to stop in about 35 minutes because we have a lot of other things that we're going to do tonight with all of you, and we want to answer everybody's questions. So I'm going to try to ask some quick questions that maybe we can get through relatively quickly. One of the most important questions I see here is, can HRT help with high cholesterol if you're pre-diabetic? I'll get that out correctly. Yeah. What do you think?
So HRT lowers total cholesterol on average, lowers total cholesterol, increases HDL, the good cholesterol, decreases LDL. So those are the numbers. It slightly increases, I just blanked, sorry, I'm having a senior moment. But in general, hormone replacement therapy improves your cholesterol numbers overall, whether you're pre-diabetic or not. But this is not a statin, okay? So, we're not gonna take somebody with a cholesterol of 300 and get them down to 120 with HRT. But it does lower it a little bit. So if you have a cholesterol problem, HRT is not gonna make it worse, it's gonna make it a little bit better. It's not gonna treat your cholesterol. So it's not a primary cholesterol medication, but it's not gonna make the situation worse. How about that?
Perfect. Love it. Okay, good. Excellent. All right, next question. Sorry. Brenda, online, this is an online question, and I am going to try to pepper in the people who ask questions in advance, but bear with me. Brenda would like to know, she says she's noticed more acne with DHEA capsules. Why? It wasn't happening before she started DHEA, so she kind of wants to know, like, well, what are you guys doing to me with the DHEA? And she's not really enjoying the breakouts.
So yeah, unfortunately, acne can be a side effect of DHEA. For most people at the 25 to 50 milligram dose, which is what we prescribe, it's not a big factor. Some people, though, are much more sensitive to it. But most people with DHEA don't get acne, but some do. And the reason is that DHEA gets broken down into estrogen and testosterone. It's the testosterone part that we're after. It's a way to boost testosterone, which is important for women. But the testosterone can cause acne. And some people are more sensitive to it than others. The bodybuilders that are taking 200, 400 milligrams of DHEA a day all fight with this, because at those doses, it's going to give everybody acne. At 25 to 50 milligrams, it happens, but much less commonly. But it sounds like you're one of the unfortunate ones. And so if the acne becomes a problem, you might have to stop the DHEA, or you could try taking it every other day and decreasing the dose further. I have found that to be successful. But it is a side effect that can happen with DHEA, unfortunately. There's kind of no free lunch. So everything has its pluses and minuses, and everything's a little bit different for each patient. And so sometimes we have to try things on, like trying on different outfits till we find the thing that fits.
Okay. We have a question that was submitted. I'm not going to say who it is in case you want things to be private. So I'm just going to ask the question, which is, are there risks of using bioidentical hormones long-term, including IUD, estrogen patches, or compounded creams?
So everything has risks, and there's also benefits, and we always weigh the risks and benefits. As I already said when I talked too long, the big picture is overall you're more likely to do better and live longer with hormone replacement therapy. But it doesn't mean bad things can't happen to you. And there are things that happen all the time. And that's just true in life. So, I elected to drive my car here today. Thankfully, I didn't get into a horrible accident. The car in front of me rear-ended the guy at the streetlight on the way down the hill. I live up in Arrowhead. Nobody was hurt, but you just never know, right? There was a little earthquake last night. It shook me up. You never know when it's going to happen. So stuff happens, and things can happen with hormone replacement therapy. So there are risks. And, the more lottery tickets you buy, and the more often, the longer you buy them for, the more likely you are to win. You still probably aren't going to win the lottery, but it's the same with anything, with hormone replacement therapy. The longer you're on it, and the more you use it, the more you're exposing yourself to those risks, and the more chance you have of something bad happening. But still, those risks are still very small, and it's still unlikely that something's going to happen. But everything, yes, unfortunately, does have risks, but they're small.
Okay, we have a really good question, and this is a question that I actually would love to know the answer to as well. So the question is, we have a Winona patient, it's not me, for a year and a half, who has recently had her bone density test done. Usually you get that done like about every 18 months, and she's 54 and says she has osteoporosis. Should the HRT dose that they are on, and I'm not sure what that is, it's not known, should the dose be increased in order to help with the bone density / osteoporosis problem?
So estrogen definitely helps prevent osteoporosis and osteopenia, and that's one of the health benefits of HRT. So HRT, most people take it because they're miserable or they have symptoms, and it's great at fixing those. But behind the scenes, it's also helping a lot of health things, and osteoporosis is one of those, and so it does help prevent osteoporosis. There are other drugs that are better at actually treating the osteoporosis. So the estrogen is going to help, but pushing that estrogen dose up too high is going to end up giving you side effects and probably not the right way to treat the osteoporosis. So you keep the estrogen on, and it helps some, and then there are other medications that you would add to really treat the osteoporosis. That would be my advice and the right way to do it.
All right. Hopefully this is an easy question. I'm going out of order too, and everyone online, I just want to say we'll do our best to get to everyone's questions. It's almost impossible with a room full of people and everyone online to get through everything. So if you see us skipping your question and you have a question at the end, please submit it to us. You can email us. We'll have Anna put an email in the chat as to where people can send their questions if we don't end up answering it at the end or by the end. Okay, so what was my question? Now I'm forgetting. See, brain fog. Okay, the question is, can you take HRT forever? Are there risks if you continue taking it, years upon years?
So very good question. And the answer is we're not really sure. There's mixed data on this. So HRT, as I said, decreases the risk of cardiovascular disease, and the longer you are on it, the longer, the lower that risk probably is. There are other risks as well that can magnify as you get older and older. So I can tell you that back in the old days, I've been practicing long enough that I was practicing before the Women's Health Initiative, and at that time we were giving HRT to everybody. We thought it was a vitamin. A 90-year-old would come in, we'd give them HRT, and we thought the data at the time said that was the right thing to do. And then, things changed. We realized, hey, this isn't a vitamin, it's a medicine. It has risks like everything else. And so the pendulum swung way the wrong direction. And so then it became, try not to give HRT to anybody. And if you do, try to minimize it as much as possible. And now we're realizing that's not the right answer either. Where that sweet spot is, we don't really have great data to say that for sure. And so my advice is that as long as the HRT is relieving symptoms and your life is better on it than off of it, any risks that are there are probably pretty small, and it's probably worth staying on it. Assuming you haven't developed a health condition where it's no longer safe, but let's put that aside. So what I advise, the average woman is on HRT for about 5 years. My advice is to, after being on it for a couple, 2-3 years maybe, or if you're younger, maybe a little bit longer, try going off of it and see how you feel. And you may feel fine. You're like, okay, I don't need this medicine anymore. There's no point taking medicine you don't need. You may feel miserable, then go back on it. And I always joke, don't do this right before your kid's wedding or something, okay? Do it at a time when there's not a lot of stress in your life. And it's okay to experiment like that. And then, if you still need it, maybe try it for another year or two and then try it again. And eventually you might find that you no longer need it. And I think that's really the best way to do this. Medicines are great. They help a lot. But better not to be on them if you don't need them, and you don't want to take stuff that you don't necessarily need. And so I think it's okay, it's safe to do that, and your body is going to be more sensitive than anything else. And even if we have studies on big populations, it doesn't necessarily relate to the individual person. And so you really want to listen to your body and see what your body's telling you. And this way of trying the experiment, how do I feel off of it? No, I still need it, and that's the way I recommend doing it.
Okay, this is an important question. The question is, why is the cost of bioidentical hormones so high? Someone says they've heard that topical progesterone is not effective. Do we recommend using pills instead?
So we answered that question at the very beginning, and maybe whoever asked, maybe they came on a little bit late. But the big picture of that is progesterone is safe when it's done correctly, and that's the big thing. At Winona, we do it correctly. We're very, very careful about that. But it needs to be done right. And so the progesterone cream is safe when done right. When not done right, not a good idea, and it needs to be done a different way. Let's answer the other question about cost. And actually at Winona, our For somebody that needs estrogen and progesterone, our least expensive option is the bioidentical cream. And the reason is that we're able to do that in our pharmacists do it themselves, not ourselves. Our pharmacists do it themselves in our pharmacy. And so we're able to keep costs down that way. It also, however you feel about this, cuts big pharma out of the equation, so they're not getting their cut out of it. I kind of like that, but and so bioidentical creams are actually our least expensive option for people because we're able to do it ourselves and keep costs down. The pills are a little bit more expensive, not that much more. The patches are a lot more expensive, and it just has to do with wholesale costs. So we had a pellet question, and we'll get to that. But the pellets are really expensive, I have patients and people that go. There are some people. I've had patients that come to me from medical spas, and they're telling me they're spending $1,000 a month on, on hormones and tests and all this stuff, which to me seems like a lot of money, considering you can do a cream for under $100 a month at Winona. So I think it's actually fairly reasonable, and the bioidentical creams are actually less money than the pharmaceutical, the big pharma pills and patches.
Great. Okay, we have a question about cholesterol. So I don't know if anybody in the room is concerned about their cholesterol, but if you are, you want to hear this question. And can HRT, this is the question, can HRT help lower cholesterol once you're using HRT? Like you already have elevated cholesterol and you take HRT, or is it not going to touch your cholesterol either way if your cholesterol is already elevated?
I thought we answered that, but so HRT will lower overall cholesterol. It will raise HDL, which is good cholesterol, and it'll lower LDL to a small extent. So it's not the primary treatment for cholesterol, but it's not going to make your cholesterol worse. It'll make it a little bit better. But if you have really high cholesterol, you probably need to be on a cholesterol medication as well as your HRT.
I'm going to try to get some variety. I think we have a lot of people that have the same questions, whether that's online or what you've submitted. So I'm going to try to pick something else. One of the questions is about being, if you are 56 and you are postmenopausal due to a hysterectomy, will HRT help with your weight gain?
So yes, HRT does help with menopausal weight gain. So hormone replacement therapy should decrease not just your weight, but more importantly, it should decrease the fat and increase your lean muscle mass. So not only should you get thinner, leaner, but in a more healthy way. It also helps decrease central obesity. That's the menobelly or what have you. And really more importantly, what's called the visceral fat, which is actually very dangerous types of fat. So HRT can help with that. This isn't a GLP-1, so it's not going to do what Ozempic does, but it does help, and it should decrease weight for most people. It's not a magic pill. You still got to do the work. Okay, you got to eat healthy, you got to exercise, but for the same given amount of appropriate diet and exercise, if you're on hormone replacement therapy, you should lose more weight than if you weren't on it at all. Sorry, I don't know why I moved the mic. I think that was the question.
That was the question. I see a good question here, but I'm going to need to ask Louisa if you can, in the chat, retype your question. I'm going to read it as it is, but I'm not clear exactly on the question. So what I see here is that she said she's received her prescription from us, and she wasn't clear on when to start. She wants to know what day is ideal to start, and can we start passing the cream after the period, during the period? I'm not really sure what that means. So maybe you understand that, Dr. Green?
Yeah, I've had the question up. I know what she's asking. Okay, so you don't have to time this around your cycle. This is different than birth control pills. The day you get the mail and it's there, start it. Okay? Because the sooner you start it, the sooner you're going to start feeling better. You want to take HRT every day. You do not want to stop this during your period. So no matter what's going on with your cycle, take your HRT every day. A while back, maybe 10, 15 years ago, we started getting this data that, and I already talked about this a little bit, that estrogen and progesterone together increases the risk of breast cancer slightly, but estrogen alone does not, which was a big surprise, really, for most of us. And so there was this thought, well, wow, it must be the progesterone that's causing the problem. Let's minimize the progesterone. So people come up with these different schemes to try to decrease the amount of progesterone to try to decrease this perceived risk. And one of the things was a cyclical HRT, where you only give the progesterone 14 days out of the month, or some people did it 10, some people would do it 14 days every 3 months. Everybody had different ways of doing this. And so that was kind of popular for a while. And over the last several years, now we're getting some data on these new ideas, and it turns out that there's really no advantages to doing it that way. And that if you try and do HRT cyclically, you don't get advantage, but you get more side effects. And so it's really better to take HRT every day. You get less side effects that way, it's easier to remember, and it works just as well. So take it every day, start it as soon as you get it, because it doesn't work well when it's just sitting in the shelf. You actually got to use the medicine. And so the sooner you use it, the sooner you'll feel better.
Perfect. Great. And everyone online, I just want to say again, thank you for being patient about background noise. We're on live in a hotel lounge, and so we are next to a bar, and there's lots of clinking of glasses and people talking, and it's hard to get it as quiet as it would be if we were just in our living room speaking to you. So thank you in advance for being patient and understanding. We're doing our best to make it, through this with minimal noise. Okay, I want to make sure to be mindful of the time. We have about another roughly 15, 18 minutes, so we'll try to get through as many questions as we can. Here's a pretty easy one, Dr. Green. Can HRT affect thyroid? Good.
This is a really common question. That's a big misconception. The big answer is it really doesn't affect thyroid to any great extent. There's some subtleties there. There's something called sex hormone binding globulin. It's a protein that binds up some thyroid. And so taking hormones can increase sex hormone binding globulin, could theoretically lower the amount of circulating thyroid that's in use. So the honest answer is, from a very scientific point of view, yes, it can affect thyroid. But from what we call a clinical point of view, which is like, okay, that's the science, like the technical science, but how do people feel? It doesn't affect thyroid enough to change anything. So if you're getting thyroid replacement, for instance, HRT is not going to all of a sudden make your synthroid stop working. If you've been on thyroid medication long enough, you know that it's a finicky drug, okay? And so thyroid is usually monitored very closely, and you usually have to adjust the dose up and down, because thyroid replacement does funny things, and like anything can affect it. And so you still want to keep track of it, and just like if you weren't on it, you may have to adjust your thyroid medicine, so it's important that you keep up on that. But the hormone replacement therapy itself should not affect thyroid in any meaningful way.
Okay, here's an interesting question. I don't think we've had this one before. We've had lots of things about HRT and weight and being hungry and gaining weight, but not this specifically, which is, why am I so hungry when I'm taking HRT? Like, what is it that's happening that's causing me to feel like I'm taking prednisone?
So for most people don't get that, but some people do. It's generally the progesterone that can cause that. The synthetic progesterones, Megace is the big example. They actually give Megace for anorexia, which is it's a progesterone, but also even Provera, which is probably the most common synthetic progesterone people use for HRT. It's also what they use. Some of you have used this for Depo-Provera, and which is a birth control. It's the same drug, and Depo-Provera is famous for making people gain weight, and it does it by stimulating people's appetite. Micronized progesterone, which is the bioidentical progesterone that we use, does that the least of any of the medications in this class. So for most people, the progesterone, that we use, micronized progesterone, doesn't stimulate appetite, or doesn't to a great extent. Unfortunately, that's not true for everybody. And so, every medicine reacts differently. Everyone reacts differently to different medications. And so for some people it can do that. It's generally the progesterone. And so really the key, if that's a side effect you're having, is to try to minimize the progesterone. So there's sort of a minimum amount we can give you to keep you safe. And sometimes we can kind of decrease what we've got you on a little bit, and it might help with that appetite stimulation that the progesterone is doing. But that's probably where it's coming from.
Thank you, Dr. Green. You're doing such a great job at being very succinct with your answers.
That's not my nature.
Dr. Green, he's chatting like I am, no disrespect. Okay, so we have another good question. One of the questions, and I love this question too, because for people in the room who are new to Winona, maybe you don't know how we operate or what it's like if you decide you want to be a Winona patient. So the question is, how do I check in with my doctor if you have a telehealth service monitoring your prescriptions and your HRT, and you're not going to somebody's office to check in and say like how you're doing? So what does Winona do to keep in touch with their patients, and how often do they do that?
So great question. The dirty little secret, and I apologize for my patients I see in person, is that my Winona patients have much better access to me than my in-person patients. So we have a messaging platform, and you can type a message in and send it to us at any time. And we answer them pretty quickly. So my ask for my doctors is to basically sort of clean out their inbox every 24 hours at minimum. We all take a day off here and there, well, except for me, but they all, everyone takes a day off here and there. I am on line probably an unhealthy amount. My wife's in the audience, she can attest to that. So I tend to answer the questions much more quickly than that. It's probably rare to have a question sit in my inbox more than a few hours at a time. But so we're very, very available to you. And we think that's really important, especially since we don't have that face-to-face interaction. And so we compensate for that by being even more available to you at any time when you have a question. The other nice thing about it is you wake up at 3 a.m. and you can't get back to sleep because you've got this thing bothering you, like about your HRT. You can get online, ask the question, and when we wake up in the morning, most of us, I think, do some of this over our morning coffee, and then we can answer that for you. So, don't do that to your in-person doctor. Don't call his answering service and ask him, hey, I got this HRT affect thyroid. Don't ask that at 3 a.m. But you can ask us because it's not going to wake us up. So it's a nice way. It's a nice way to do it. The other thing that we do is we do these follow-ups. And so when I designed this, I said, what would I do if this was a patient in my office? So, you see somebody for the first time, you write them a new prescription, and then I always have them come back in 3 months. How's it going? And then sometimes everything's great, we don't do anything different, or sometimes make some adjustments. And then I'll write them a year's worth of prescriptions, and I'll say, look, if everything's great, come back and see me in a year. Because quite honestly, it's not fair to you to give up your whole day to come in just to tell me everything's great. So if it's not, make an appointment, and in Winona, that's send me a message. And otherwise, let's check in every year and just make sure things are okay. So that's what we do with Winona. You get a follow-up. We call it the 10-week follow-up, which is kind of funny. I'm going down a rabbit trail, sorry. But because when I first saw it, I thought 10 weeks is going to be about the right amount of time. And it turned out 10 weeks was a week too early because people's refills weren't coming up for 2 more weeks. And so I say, gee, we should increase your medicine. And then, gee, nobody wants to wait 2 weeks to get that new prescription. And so we shortened that to a week. And so the 10-week follow-up is actually 11 weeks because the timing worked out. And the problem was that nomenclature stuck. And so everybody had called it the 10-week follow-up. So we just keep calling it the 10-week follow-up, even though it's really an 11-week follow-up. So we give you your prescription. We check in with you at 10 weeks, 11 weeks, and then again at a year. But feel free, please, to check in with us anytime, especially if things aren't right or if you have questions. And by the way, any of your questions that aren't being answered, if you're a Winona patient, ask your doctor. We're happy to answer those. The other thing, sorry, one more thing. I know this isn't succinct, and I just want to apologize for this. Anyone who's been on Q&As before was it the last one or the one before? I think we did a 2-hour session because that's what it took to get everybody's questions answered. So it kills me not to answer all your questions, but I got a room full of people here, and we promised them some social hour. So we really do have to cut this off, and that's the reason. Well, come back next month. I'll talk as long as you need. Okay.
And also for the people in the room, you can come to Dr. Green's table
and ask me about your pellets. I'm sorry.
You can just, don't bug him because he loves to answer your questions. So, and I'm sorry to pick you out like that, but I think that everybody here is going to feel free to ask their questions. We're getting through most of them, but just please.
I'm a little passionate about this if you haven't
He
figured it out.
loves to talk about this, so you'll get your question answered, I promise. If you don't hear it right now, you will get it answered before you leave this evening. So we had a question from Lori online. She's asking us about DHEA. She wants to know if we provide DHEA instead of testosterone, it's her understanding that DHEA would create testosterone if the estrogen levels were balanced. Is this correct? And are there other benefits of DHEA?
So close. So the truth is that we can't do testosterone with the type of telehealth that we provide. Testosterone is a controlled substance, and with asynchronous telehealth, you're legally not allowed to do it. That's sort of true. There were some rules that got temporarily changed with COVID, and we sort of made a decision not to use COVID rules because we were afraid, and it's happened, that they would sort of yank the rug out from under everybody, and we were giving somebody something, and all of a sudden we can't do it anymore, and we didn't think that was fair. So we followed like the stricter rules with prescribing and everything. Again, we try to do everything by the book just as well as we can. And so we really can't prescribe testosterone. The other thing about testosterone is it's tricky. And there's what's called a narrow therapeutic index. And what that means is that the difference between the dose that helps and the dose that causes bad side effects is really close, and it's really touchy, and it's really difficult to do well, which, by the way, is going to be the punchline about the pellets, because that's one of the problems with pellets, is it tends to overdose the testosterone. DHEA is nice in that at the dose that we use, 25 to 50 milligrams, it will increase testosterone levels, but at that dose, you're not going to push someone's testosterone levels really outside of normal range. So we're not doing the kind of testosterone that some of my buddies in the gym use to look huge. That's not what this is for. And there's nothing wrong with that. I mean, if that's your thing, go get them. I've got some really good friends that are giant, and I like watching them, It's not what I choose to do, but that's okay. But that's not what we're doing with Winona. This is just enough to get you back to that normal level so that you can feel like you did, 10, 20 years ago. And you can get that libido back, and it helps with weight loss, and it gives you more energy. And that's really what it's all about. So DHEA gets broken down into estrogen and testosterone. The estrogen is a small component. There's this warning on the Mayo website, and I think Cleveland Clinic too. You shouldn't take DHEA if you're taking estrogen because it increases your estrogen levels. That's true if you're taking bodybuilder amounts of DHEA. And in fact, the male bodybuilders use estrogen blockers so that the DHEA doesn't cause estrogen side effects. But at 25 to 50 milligrams, the estrogen component is really pretty small. And so it's really the testosterone that we're after with the DHEA. And again, we're trying to hit that sweet spot to get you into a normal level without pushing you into side effects like the acne and the hair thinning and the oily skin and those kind of problems that people get with testosterone.
Okay, we're going to do 2 more questions, everybody. And then we have... So don't leave. Okay, so because there's 2 things that are really important that are going to follow this. Sorry, all the people online. We wish you were here. We're coming soon to a state near you, so hang tight. We will get to you. But before we end, 2 more questions. Next question is, let me find it. Okay, after starting estrogen and DHEA, is it common or uncommon to have changes in your chemistry where yeast infections are more frequent?
So it's not so much the DHEA, but the estrogen, and it's not really yeast infections. So what happens is estrogen makes the vaginal tissues more healthy. It's a great thing. So one of the problems with the menopause transition is that because the estrogen levels are getting lower, the vaginal tissues start getting thinner and less healthy, and there's dryness and pain. Sometimes sex becomes uncomfortable. It can cause a lot of problems. And estrogen helps make those vaginal tissues healthy again. And part of that are the glands in the vagina. And that's actually kind of what we're after. So the way it fixes vaginal dryness is by increasing the amount of discharge that those glands are making, like when you were younger. And that makes life more comfortable. It makes sex more comfortable. When the vaginal tissues become more healthy, it supports the bladder, so it can help incontinence, it can help bladder irritation. So there's a lot of real benefits to that. But when this has been going on for a long time, and then all of a sudden you're producing sort of your normal healthy discharge again, it's like weird. And so some people think, gee, I have a yeast infection. It's also possible that you get a yeast infection, but a lot of times people kind of misunderstand this because they're used to, oh, all of a sudden I have this discharge again, I've got a yeast infection. The other thing is that when you have more discharge, outside skin doesn't like to be wet and moist all the time, and so it can get irritated. In a baby, we call it a diaper rash. So nobody likes to call it that, but it's basically the same thing. And so sometimes when that discharge picks up, it can cause irritation on the outside. And that can be itchy, and it can feel like a yeast infection as well. The trick to that is diaper rash ointment, and that can really help. So if you're having irritation, a little diaper rash ointment actually can really solve the problem. You usually don't need that for a long period of time, but just to kind of get that irritation out of the way. So I think that's most of what people are experiencing, what they think is a yeast infection. It is obviously still possible to get a yeast infection, but it's really a sign that the hormones are doing what they're supposed to be doing, and your vaginal health is coming back. And so sometimes a little more exuberantly maybe than you want, but really on the balance, a good thing.
This is our last question. We're going to follow up with our friend over here that had a question about the pellets. Let's see. So I just want to make sure we didn't forget, because we started with you, want to make sure we end with that. So Dr. Green, do you remember where we were with it?
Oh, I can talk about pellets.
Dr. Green, we have 3 minutes. So, okay, here we go.
Okay, I can't talk about pellets in 3 minutes, but I'll do my best. So pellets has become very popular in some circles, and the pellets are basically injected underneath the skin. There are long-acting hormones that inject under the skin. The nice thing about the pellets is you get them once, and they're good for 3 or 4 months, and so it's very convenient that way. The downside of the pellets, just from that point of view, is it's an invasive procedure where somebody sticks a big needle and shoves something under your skin, and it can be uncomfortable, and there's some small risk of getting infections and that kind of thing. The problem with the pellets is that there's no like takesies backsies. So once you put these in, they're there, and if you don't like it, you're stuck with it for 3 or 4 months. Whereas if you don't like your pill or your cream or your patch, you just stop using it and it's gone. And so that's one of the downsides of the pellets, is that if you get overdosed or you just don't like the side effects, you're kind of stuck with it for 3 or 4 months, which is kind of a bummer. The other thing about the pellets that I don't particularly agree with is that most of the pellets are testosterone based. The concept is, if you give somebody enough testosterone, the body will metabolize that testosterone into estrogen. And so people say, well, we're giving you your estrogen, but we're doing it through testosterone. And I think that's kind of a backwards way to do it for a woman, because the primary hormone for women is estrogen. They definitely need some testosterone, and that's been neglected, honestly. And I think people are understanding that more and more, is that women do need some testosterone. But testosterone is a primary hormone in men, and men need a little bit of estrogen and a lot of testosterone. Women need a little bit of testosterone and a lot of estrogen. And so this idea of, well, we can get your estrogen levels up by giving you a whole bunch of testosterone is sort of the backwards way of doing it. And I've seen some really unfortunate side effects from overdosing testosterone. So the annoying things are the acne and the hair thinning and the oily skin. But give enough testosterone, you can get male pattern baldness that may not be reversible. You can get voice deepening that may not be reversible. And like the bodybuilders that do this, they get clitoromegaly, which some people don't like, and that can be reversible as well. So that's kind of at the very extreme. So if you overdo testosterone, it can have some really unfortunate side effects. So I have a problem with the pellets for those reasons. I think there are some women that do respond well to it. My personal feeling is that the number one reason that people get so many pellets is that pellets are very lucrative for the obstetrician that's doing it. And so there is a money factor in driving this. It's a way to boost income in a practice. And I'm going to go down a little rabbit trail, just to be fair. When I first started practice, you could do 12 to 15 deliveries a month, and you could make a good living. Reimbursements have gone way, way down. And now you've got to do 30 or 40 deliveries a month to make the same amount of money. And that's sort of a ridiculous lifestyle for people. So everybody's kind of looking for other ways to make a living. Pellets has become a very popular way. A lot of obstetricians are doing cosmetic surgery, which there's nothing necessarily wrong with that, but they invested in lasers. They're doing vaginal rejuvenation procedures and the Mona Lisa and these other things that isn't really sort of what we primarily were trained for. Doesn't mean those things are wrong, but that's really what's driving this. Is you used to be able to do a reasonable amount of deliveries, make a good living, but I can tell you in private practice, every year I found that I was working 10% harder and making 10% less. And so what happens is people scramble to look for other ways of earning money. And this doesn't make it wrong, but it does incentivize to kind of probably do it more often than it really ought to be. So that's my feeling on pellets. It doesn't mean it's necessarily wrong, and it is another tool in the toolbox. Obviously not something we can do at Winona because it requires a physical procedure. And again, there are people that do well on the pellets, but I think it's overused, and I think there's a financial incentive to overuse it, unfortunately. So that's my 2 cents.
Thank you. Okay, everyone. So people online, this is the part where we say goodbye to you. I'm so sorry. Anna, we love you. Thank you so much for being here. Everyone in the room, stay here. We're gonna, we're gonna Taylor Swift it here for you. We are gonna show you a very fun, short menopause comedy. But before we do that, my friend Lacey Stone is going to come up here and talk about some fitness. Everybody online, thank you, and we will see you in a month. We'll see you soon. Thanks so much, everybody.